Dear esteemed chairs, dear audience, dear colleagues, welcome to my 9-month progress report presentation. My PhD topic is about key differences in sex-specific outcomes after anterior cruciate ligament reconstruction. My name is Krisztina Kornis. I work as a physical therapist, and I'm a first-year PhD student. In this slide, you can see the individuals supporting me on my PhD journey, and I came here with a clear vision, which is to revolutionize physical therapy assessment and treatment with innovative methods, and my mission to achieve it is to explore innovative strategies in physical therapy by conducting research. I have 2 ongoing projects at the moment. Both of them are investigating the effect of sex on the outcome of anterior cruciate ligament reconstruction surgery, with a particular focus on graft failure, graft tear, and arthrofibrosis. Let me introduce you my first project, which is investigating the effect of sex on the outcome of anterior cruciate ligament reconstruction surgery. This is a systematic review and a meta-analysis. Anterior cruciate ligament is a double bundle dynamic ligament which maintains the knee stability in dynamic movements. Only in the United States there are more than 100,000 ACL reconstruction surgeries in every year, and we know that the incidence of a second ACL injuries in athletes after ACL reconstruction is nearly 6 times higher than in the healthy controls. Despite the high prevalence, I investigated the literature and realized that different sources publish different results. Some articles mention that both sexes have a similar chance of experiencing a second ACL injury, while some authors mention that females have a higher rate of secondary ACL injury, and some paper published that males have a trend towards higher re-injury rates. We know that some anatomical differences, hormonal effects, biomechanical factors, and variation in the neuromuscular control can influence the success rate of ACL rehabilitation between sexes. But the question is, what are these differences and what are these effects exactly? In this slide, you can see the quadriceps angle and the dynamic knee valgus. Quadriceps angle plays an important role in knee biomechanics. Due to anatomical reasons, females have a higher quadriceps angle than males, and one of the most common altered movement pattern is dynamic knee valgus, which is often associated with a higher quadriceps angle, which can increase the risk of non-contact ACL injuries in female athletes. We also know it from the literature that higher estrogen level can increase the risk of ACL injury due to the hormone's effect on laxity and neuromuscular control. There is a need to recognize the different factors that can influence the success rate of reconstruction, and my aim is to identify if there is a difference in the clinical outcome after ACL reconstruction between males and females. My clinical question is if there is a difference between males and females in the clinical outcomes after anterior cruciate ligament reconstruction. I aim to investigate patients who have undergone ACL reconstruction surgery and completed rehabilitation process. I would like to compare females to males, and I identify 2 outcomes. The first one stands for the graft failure outcome, like graft tear, revision surgery, or return to sport failure, while my second outcome summarizes the knee instability outcomes. I hypothesize that females have worse clinical outcomes after ACL reconstruction compared to males, and if we can prove this hypothesis is true, we can immediately start developing sex-specific protocols for rehabilitation plans, which may enhance the success rate of ACL reconstruction. Here you can see my search key. We identified 4 domains. The first and the second stands for the ACL and the surgery. The third one summarizes the outcomes, and the fourth one stands for the sex differences. The search was conducted in 3 databases. We had more than 11,000 articles, but after the screening process, we ended up having 35 articles and also identified 8 new inclusions in total from the citation chaser. Currently, we are working on the outcome analysis. There are many outcomes that we would like to examine, but we finished the graft tear outcome, which I would like to present you. In figure 1, we can see the graft tear outcome visualized in a forest plot. Graft tear is one of the most important outcomes after anterior cruciate ligament reconstruction surgery, as it is the most obvious indicator of graft failure. If graft failure occurs, it can lead to knee instability, inability to return to sport, pain, a reduced quality of life, or also revision surgery, which means there's a second surgery for the patient. Here we analyzed event rates, compared females versus males, the graph there, and we summarized 26 articles with nearly 11,000 patients. Most of the articles are retrospective cohort studies, but there are also some randomized controlled trials among them. The heterogeneity is 60%, which is moderately high, and the reason of that is probably that we pulled together athletes with patients from the general population and also different age groups above 18. We calculated odds ratio. Odds ratio below 1 means that males have a higher chance for experiencing a growth there, and odds ratio above 1 indicates the same for females. Our pooled odds ratio is 0.9, which means there are approximately 10% more chance for males for experiencing a growth there. And this result is neither clinically relevant nor statistically significant. Therefore, at the moment, it does not support the need for developing sex-specific protocols. However, I would like to highlight that this is only one of my outcomes. Therefore, I will need to get back to this question later on when I have all the outcomes and all the subgroup analysis completed. Since my last progress report, we finished citation chaser, data extraction, and currently we're working on risk of bias assessment and the figures and tables. Let me move on to my second project, which is investigating the effect of sex on the prevalence of arthrofibrosis after anterior cruciate ligament reconstruction surgery. This is also a systematic review and a meta-analysis. Arthrofibrosis is an abnormal fibrotic response which can lead to excessive scar tissue formation in the joint. The most complaints are difficulty to extend or flex the knee, so there is a lack of range of motion. The incidence of arthrofibrosis is between 1 and 12% after ACL reconstruction in the United States, and while the majority of the patients can be treated with non-surgical management, like physical therapy and mobilization, around 4% of the patients need additional surgery, like scar tissue removal or even revision surgery. Arthrofibrosis can significantly impair the functional outcomes and may prolong the rehabilitation, and my aim is to identify if there is a difference in the prevalence of arthrofibrosis after ACL reconstruction surgery between males and females. My clinical question is if there is a difference between males and females in the prevalence of arthrofibrosis after anterior cruciate ligament reconstruction surgery. My PICO framework is pretty similar than in my first one. However, here as an outcome, we identified arthrofibrosis and revision surgery due to stiffness. Our hypothesis is that arthrofibrosis is more common in females than males after ACL reconstruction surgery. And why is it important? Well, because by understanding sex-specific risk factors for arthrofibrosis, we can guide the development of rehabilitation programs that are optimized for females and males. Here is my preliminary search key. The search was conducted in 3 databases, and it led me to my key articles. And one of the most important aspects for us was to find articles which provide different sex-specific results, so we can compare them later on. As a summary, I would like to highlight that currently there are very limited sex-specific protocols for musculoskeletal conditions, surgery, and rehabilitation, and with my projects, I aim to address this gap. I truly believe that in some aspect, we all have to be a little bit innovators in our fields. Therefore, I would like to thank you for your kind attention with one of my favorite quotes: "Do not follow where the path may lead, go instead where there is no path, and leave a trail." Thank you for your attention.
Thank you so much, Kristi. Any questions from the audience, colleagues?
Congratulations to your very nice and interesting presentation. So my question is that, if I am correct, there is an existing phenomenon among athletes that they have a fear of re-injury and re-trauma. And what do you think that how can this fear affect their movements or alter their movements and maybe your results? So does this fear have an effect maybe on your results, or how do you see it?
Thank you for your question. This is actually a very important question, and we come along during the screening process because one of the articles that we had included in our study, it actually did a comparison between a group with kinesiophobia, which means that they are afraid of the re-injury, they are afraid of the getting involved in different sports because they are afraid that they're gonna get injured or experience pain. And they compared people with kinesiophobia without kinesiophobia. And actually, we were thinking if we can include this article or not, because we were afraid that it's biased by this question. But the thing is that we actually don't know exactly what about the other people that we included in this analysis, which is more than around 11,000 people that we investigated. So we don't know exactly if they experienced kinesiophobia or not, because those articles were not specific about it. So we decided to include this population as well. But to answer your question, I think kinesiophobia may have an effect on especially the return to sport, because they might not willing to take part in this kind of sport activities. However, the laxity, the instability of the knee joint can be measured objectively. So that's also a graft failure outcome, which is important to investigate if we would like to answer this question.
Thank you very much for your precise answer.
Oh, sorry, please.
Thank you. It was a wonderful presentation. I was wondering about your first project, that your secondary outcome was the knee instability. Could you be more specific, and can you explain me those scores? Because you mentioned like 4 or 5 scores there.
Thank you for your question. Let me just get back to that slide here. So the second outcome that we wanted to analyze is the knee instability outcomes. Here we actually decided to analyze some patient-reported outcome scores, which is IKDC score, or Degner score, or Lischholm score. These are specifically analyzing if the patient had any symptom, pain, how did they describe their quality of life, and this kind of things. And Lachman test and pivot shift test stands for a manual test, where we can actually hold the patient's leg, and we try to anteriorly move the tibia while trying to hold the femur. And if this laxity is significant between the two legs, we consider this test positive.
And I have another question too. Those are just for the knee, or for other joints as well we can do those tests? Or what tests can we do in other joints, or what can be used in other joints, for example?
Thank you. These tests are specifically for the knee laxity. In physical therapy setting, we have many manual tests where we can actually assess joint laxity, but for every joint it's different.
Thank you.
Thank you.
Okay, one question on the left.
So, thank you for your wonderful presentation. Have you considered, sometimes they use physical therapy afterwards, or the rehabilitation, how long it was? Because it's generally it's a diverse thing, at least as I know from some sportsmen around my surroundings. So have you considered that as well as a subgroup?
Yes. If I get your question correct, you're asking if I wanted to include patients who completed rehabilitation and to check if someone did complete it and someone did not, and do a subgroup based on that?
Yes, or the length of the rehabilitation time.
So what we did here is that we only included articles where the patients finished physical therapy. And I think it's very important because if you want to be specific about ACL rehab, then we cannot talk about rehabilitation without finishing some specific exercise programs. Therefore, based on this, we don't plan to do a subgroup analysis, but our follow-up is 2 years. And the reason of that is that after ACL reconstruction surgery, we really need the patient to participate in physical therapy and rehabilitation for at least 9 months, but it's sometimes a year, especially if we are working with younger generation, because the younger population are more, there's more increased risk for re-tear the graft.
Thank you very much.
Thank you.
Okay, so thank you. Okay, my question would be that is there any objective motion analysis method that analyzes the dynamic knee valgus?
Thank you for your question. Well, to answer the question, there is, but I would like to highlight here that dynamic knee valgus is only one aspect that we would like to investigate. So experiencing ACL tear or a graft tear, it's a very complex question. So we cannot just grab dynamic knee valgus. However, that's very well examined in the literature. And best of my understanding, there are many objective evaluation methods that are focusing on these altered movement patterns and also dynamic knee valgus. Some of them are very complicated and very complex systems, like OptiTrack system, where you actually need to place some markers on the patient, and before they start to do the assessment, you have to place these markers on. But there are some other maybe easier or not so complicated softwares available in the market. They actually use easier mathematical algorithm to analyze if the patient is having these kind of altered movement patterns. And I think it's the future of patient assessment, because these altered movement patterns are very difficult to visually analyze. It needs a lot of time and effort from the physical therapists to learn this kind of analysis.
Thank you so much for the very lively discussion, and thank you, Kriszti, for the presentation.
Thank you.